So next is V14, and it's hemorrhoids. A 27-year-old man presents to your clinic complaining of fresh rectal bleeding and constipation. How will you assess him? So take a history including change in bowel habits, quality and quantity of the rectal bleeding, any pain and defecation, previous history of hemorrhoids or other red flag symptoms to rule out rectal cancer and inflammatory bowel disease. Perform an examination, rectal examination, to look for the skin tag, anal fissure, hemorrhoid, and rectal malignancy. What's the difference between internal and external hemorrhoids? So external hemorrhoids are the dilated vascular plexus below the dentate line in the squamous epithelium. They present with the severe thrombosis and pain, perineal hematoma, and develop into the skin tag if it's left untreated. Internal hemorrhoids are engorged. These are symptomatic, dilated or engorged anal cushions above the dentate line covered with transitional communal epithelium. They range in the severity from the first to 4-degree relatives. First degree hemorrhoids bleed, and 4-degree hemorrhoid irreversibly prolapse. So the patient has been constipated for many years. On the mission, there are second-degree hemorrhoid. How will you treat him? So in keeping with the Montgomery ruling, I would discuss all the treatment options of the patient, including no treatment at all. And I would initially offer him conservative measures such as stool softeners, changing in his diet to treat the cause and prevent recurrence with top. And if the patient requires formal treatment, then I would perform a rubber band ligation in outpatient after counseling the patient and taking consent. And I will explain to him the risks of pain, bleeding, and recurrence. I would offer a patient information leaflet by the trust regarding the stepwise approach to the management of the hemorrhoidal disease. When would you consider operating a hemorrhoid? What would you do? So I would operate on 3rd or 4th-degree hemorrhoids, and also keeping in view with the patient's symptoms. There are 3 surgical options. So one is conventional hemorrhoidectomy called open Milligan-Morgan hemorrhoidectomy, and then the hemorrhoidal artery ligation in the form of THD or HELO, and then staple hemorrhoidopexy. A recent meta-analysis of staple versus conventional surgery showed that the staple procedure had a higher rate, longer-term risk of recurrence, prolapse, and additional surgery. Keeping with the NICE guidelines, I offer him hemorrhoidal artery ligation HALO as a first-line therapy for 3rd and 4th-degree hemorrhoids. If this is unsuccessful, the patient wishes for this intervention, I would offer him hemorrhoidectomy following the appropriate counseling. What are the complications? Post-op complications following hemorrhoidectomy? So it's pain, bleeding, urinary retention, incontinence, primary and secondary hemorrhage, and late anal stricture. Secondary bleeding is usually due to the infection. Botox, topical GTN methods have all been shown to reduce the post-op pain. Thank you.